All right, thank you for those really truly outstanding lectures. I am pleased to introduce both of our esteemed speakers here, Dr. Szabo and Dr. Corey, who are here to answer your questions. We will just get started right away. There are a number here on alcoholic liver disease, so I'll start with Dr. Szabo first. How do you prescribe NAC in alcoholic hepatitis in terms of dosage and duration?
Thank you. So, based on the study that was published in the New England Journal of Medicine, the administration of NAC, in addition to the 30-day prednisolone, improved survival at 1 month and didn't change survival at 6 months, which was actually the primary endpoint of that particular study. The dose used in there was on the first day, they used 150/50 or 100 milligram per kilogram N-acetylcysteine in glucose giving intravenously, followed by another 100 milligram per kilogram IV in 5% glucose for the remaining of the day. So I think simply if one just uses like 100 milligram per kilogram NAC in a 5% glucose in 1 liter and given over like 15, 16 hours for between day 1 and 5 of the hospitalization, that should be sufficient. And keep in mind just to keep the prednisolone on board
Right.
for 30
Okay.
days.
Great. And so a follow-up question here. In a patient who has known heavy alcohol use presents with labs consistent with alcohol-associated hepatitis. So outside of doing the usual acute viral hepatitis labs, do you send off a complete full liver evaluation or do you just go ahead and treat as if it's alcoholic hepatitis?
Well, I think in typically in my practice, what we would want to do is to rule out other known liver diseases. So if the patient had some of those studies in the past, then we wouldn't send it up every single time. But if they haven't, then I would want to rule out alpha-1 antitrypsin deficiency, hemochromatosis components, and looking for any other underlying autoimmune panels, even in young females in particular, to rule out potential other type of liver diseases. And just as a reminder, if there are any questions remaining based on the laboratory tests, then have a relatively low threshold for doing a liver biopsy.
Okay, great. Dr. Corey, would you comment on those who have a normal BMI and NASH regarding weight loss, exercise, and is there any utility for FibroSure in assessing fibrosis in those cases?
Yeah, that's a great question. We are seeing more and more what we call lean MASLD, what we used to call lean NAFLD, and they're patients who have a BMI of 25 or less, or if they're Asian, 23 or less. Those patients still can likely benefit from some weight loss, and we recommend a 3 to 5% weight loss, really trying to focus again on a hypocaloric diet, Mediterranean diet. We do for sure for those patients think about exercise at the same degrees, 150 to 250 minutes per week, aerobic exercise, or slightly less, 140 minutes per week of resistance training. But really changing diet, exercise, and if there is weight to lose, trying to think about maybe a BMI goal of 20 or 21 for those patients. The FibroSure is a test that it is not unreasonable to send, but it doesn't have the performance characteristics and the accuracy, say, of the NAFLD fibrosis score, or more importantly, the fibrosis 4 score. So we generally recommend that people use the fibrosis 4 score for first pass. And then if they need additional screening, moving on to the ELF score or elastography.
Okay, all right. Great. Actually, so what maybe I'll just ask you this. This is a question sort of related to that very topic. So what is the variability of different tests to assess the stage of fibrosis, sort of using imaging, ultrasound, CT, MR, FibroScan, or labs like FIB4 or FibroSure? And an extension to the question is there a difference in the tests? If there is a difference in the tests, what do you use as sort of the preferred method?
Well, there certainly is a difference, and all of these tests, probably minus the MR elastography. So FibroScan, ultrasound elastography, fibrosis 4-score. CT is not helpful, and there isn't a CT elastography protocol. So we're really thinking about FibroScan or vibration-controlled transient elastography, also called FibroScan, ultrasound elastography, FIB4. All of those have good performance characteristics for saying little to no fibrosis or significant fibrosis. When you try to compare, say, can they differentiate between a stage 2 or stage 3, they're not particularly good at that, but they have very good performance characteristics. FIB4 is best for ruling out advanced liver disease. FibroScan and ultrasound elastography are also very good for ruling out. MRE is good in both cases, so can rule in and rule out advanced fibrosis. So the best test is MRE. It's just a difficult one to start out with in terms of insurance and resource allocation.
Okay, great. Thank you. Dr. Szabo, let's see. Oh, is there ever a scenario where there would be a true contraindication to initiating steroid therapy in the acute?
Absolutely. So it's a very important question and something to remember. So we don't want to start prednisolone in patients who have any kind of infection. In fact, if there is a high level of suspicion of infection, it's perfectly fine to wait for the blood cultures or whatever cultures to rule out the infection itself and start steroid afterwards. There are clinical studies that show that by waiting a few days and controlling infection, prednisolone is going to have a survival benefit as opposed to just starting out without actually stopping any kind of ongoing infection. Keep in mind that alcoholic hepatitis is a disease that is going to last for several months. So waiting a few days or even a week is not going to make a huge difference. Other contraindications is massive GI bleed and also hepatic encephalopathy. I think those are the three components where I would be, absolutely not giving prednisolone to start with.
Okay, there's a question here about GLP-1 meds for actually both of you. So Dr. Szabo first, is there any role for using a GLP-1 medicine for alcohol dependence? This person said they've heard anecdotes about decreasing
so I think there are more than anecdotes related to this concept, but I would say that, it's too early to jump the gun, and I would recommend not to use GLP-1s for, particularly not for alcohol dependence or alcoholic liver disease at this point. There are actually clinical studies that are initiated to evaluate the potential reduction in alcohol craving. And in fact, there is data that suggests that GLP-1 usage reduces the alcohol craving in individuals, but I think we are not at the point of actually recommending that. Another component is I would definitely would avoid using GLP-1 drugs in acute alcoholic hepatitis, because keep in mind that these drugs actually reduce appetite, and one of the major component and the benefit for alcoholic hepatitis is good nutrition. So if anything, these patients actually need to have and eat and encourage their appetite, not suppressing that.
Okay, and Dr. Corey, that question came up through about semaglutide for patients with NASH and diabetic retinopathy.
It's a good question. So there are some reports of worsening of diabetic retinopathy in people started on semaglutide. The mechanism is not known, but it may be due to a rapid improvement in glucose. And so I know that semaglutide alone, when started without MASLD, in patients with diabetic retinopathy, it should be monitored and they should undergo serial monitoring for that. And so I would have the same recommendation. If you have a patient with diabetes who you're with MASLD, who you're starting a GLP-1 on, you do want to be looking and thinking about diabetic retinopathy if they have a rapid decrease in their glucose, and certainly doing serial exams if you feel like there might be any difference. But I wouldn't treat them differently than any other patient.
Okay, so we'll just continue on with therapies here, Dr. Corey. There's two questions here, one about using vitamin E, and then another one on the role of statins.
So vitamin E, is recommended to be used in carefully selected patients. The guidelines still say in biopsy-proven MASH in patients without diabetes, and that's because that's the group that it's been studied in. There is a meta-analysis that suggests that vitamin E over time may help decrease the risk of decompensation, although that hasn't borne out, or that hasn't been studied, of course, in clinical trials. And in the main clinical trial, the Pivens trial, it didn't improve fibrosis. I think we have better therapies than vitamin E. And I don't recommend starting it for patients who don't have at least some degree of fibrosis or confirmation of MASH rather than just steatosis. Statins, the data suggests certainly that they're beneficial. They reduce cardiovascular disease risk in this group of patients, and there's some data to suggest that they may decrease the risk of hepatocellular carcinoma and liver fibrosis. Again, not enough to start a statin alone for the treatment of MASLD, but most of our patients do have a statin indication, and so I recommend that they be started on a statin if they have another recommendation based on usually their ASCVD risk score.
Okay, great. And Dr. Szabo, do you ever prescribe medications for alcohol use disorder to help with abstinence?
Yeah, so I think that's an area where hepatologists or even primary care physicians could be kind of advancing the field. It's very clear that the long-term survival of alcoholic hepatitis patient is really somewhat dependent on the alcohol addiction component. So we know that acamprosate is safe even in the face of ongoing liver disease, and that's typically a 666 milligram 3 times a day dose that, in this population, people the compliance with medication might be an issue. I would say that starting it's fine, but you probably want to involve a behavioral therapist or somebody who is a addiction expert to help these patients for long-term abstinence.
All right. Well, wonderful. So we're a little over. I think we're going to end the session here. I want to thank Dr. Szabo and Dr. Corey really for a fantastic session. We will move to our lunch break, and so we will return back here at 1:10 East Coast time, continue on with liver disease and then the pancreas. So thank you.